Well, my name's Sydney. I race women's professional motocross. I love everything about motocross. Like jumping. There's never a dull moment when you're riding. Every lap there's something different that you didn't do the lap before. Nothing's ever the same. I went off this jump and a guy came up behind me and I didn't even know he was like behind me, and I went off of it. I was going into this corner and he came up and he just T-boned me. And then I crashed, and when I crashed my shoulder just like went back like that. I landed on it like that. About 2 months later it started slipping out of place. And so that's kind of when I figured that something was wrong with it. But my dad told me that it was fine, so I went and I raced my first pro national, and I crashed again on my shoulder because it slipped out of place. You have to have a lot of strength and endurance to be able to control a 200-pound bike. The tracks are always really rough. So, you're coming into braking bumps and you have to be able to get your bike to settle down into them. And if you're going off a jump and your bike goes sideways, you have to be able to kick it backwards so it's straight when you land. And that's also some of the main problems that I've had with my shoulder. I went off a jump and I couldn't work out to get my shoulder. I didn't have the strength to be able to control my bike, and I'd go off a jump and I'd get kicked sideways, but I couldn't bring it back because I didn't have the strength to do it. And that's kind of when my dad told me that I was done until I had it looked at.
Sydney Babcock is a patient who showed up in my clinic, and here's this girl who's quiet, a girl. She barely looks like she's old enough to know how to drive, and turns out she's this high-level world-class motocross racer.
He's never raced motorcycles, but Dr. Chris Wall knows athletes. He's a UW Huskies team physician and an orthopedic surgeon who treats his patients at the University of Washington Sports Medicine Clinic.
She'd had several shoulder dislocations while riding her motorcycle, and multiple crashes that had resulted in bone loss from the back of the humeral head. We'd discussed the different options that were available to try and stabilize her shoulder. One of the critical things for her, I think, was to get back and race, and to get back at a reasonable time, because she's at a point in her career where she was about to or had just turned professional. And so it was very key for her to get back and ride at that high level. But of course she had to have a stable shoulder to do it safely.
Oakley, go get it.
When people dislocate their shoulders and they're out for a long time, or they've had many dislocations, being out will cause the front part of the socket to grind a hole in the back part of the articular surface. So instead, where you would normally have a surface area that comes all the way out to the edge here, you've got a missing surface area where my finger is. The problem with that is that even if you fix the ligaments, there's a certain range of motion in which that defect is going to find the front of the socket, and the shoulder will continue to dislocate. So even within relatively small motions, the shoulder keeps dislocating.
Dr. Wall has developed a surgical procedure that addresses the bone loss patients experience after repeated shoulder dislocations. After a consultation with Dr. Wall, Sydney and her parents discussed the possibility of choosing this relatively new technique.
He wanted to know, was she willing to take this chance? We knew going into it that there wasn't that many that had been, put through this. She was willing to do it, knowing that there was that chance that this was going to solve her problem.
Dr. Wall's procedure, called the Daisy Graft, is the result of the painstaking process that's involved in developing a new procedure. As a UW physician, in addition to seeing patients and performing surgeries, Dr. Wall works on perfecting new techniques that improve patient care. The Daisy Graft procedure is different from what surgeons have been doing for years to stabilize a dislocating shoulder.
Traditionally, what we've done to try and fix this is, because this is a relatively hard place to get to in the shoulder with open approaches, we've tried to fix it by adding bone to the front of the socket. So if you imagine, if I add more surface area where my fingertip is here, even if that defect finds the front of the socket, the shoulder still can't dislocate. But that's not a very anatomic approach to the problem of there being missing bone here.
The goal of an anatomic repair is to restore the patient's normal anatomy. In the Daisy Graft procedure, Dr. Wall drills holes in the head of the shoulder bone. Then he inserts synthetic bone plugs into the holes. This restores the surface of the shoulder head to its normal shape. This procedure is performed arthroscopically through small incisions, using a camera to see the inside of a joint and guide the surgeon's instruments. Recovery time is shorter compared to open surgery, and there's minimal scarring.
She came out of there with, I think, 5 little tiny holes and no stitches, nothing. It has been probably the best choice for her to be able to do what she enjoys, and not having 6 months of recovery and a huge scar. And the recovery was really, really fast considering what she had done. Sydney was really a good little patient. She really was. She really did follow the guidelines that Dr. Wall had set for her, because bottom line, she wanted to go back and race this summer.
I'm really happy that I had the surgery. I mean, my shoulder feels so much better. Like when I'm riding, I have the strength now and it's not slipping out of place, and I feel like I'm more comfortable on my bike because I'm not afraid that my shoulder's going to slip out and I'm going to crash.
The surgery that repaired Sydney's shoulder is still relatively new, but her shoulder wasn't the first one that Dr. Wall repaired with the procedure. That honor went to Eric Ogard.
So what do you guys want to do?
I want a bat.
You want a bat first?
Yeah, bat first.
You guys want a bat?
Yep.
Am I pitching?
Eric's right shoulder problems began years ago.
I dove into a swimming pool and my arm came out of the socket and immediately popped back into the socket. I didn't really know what it was, but in retrospect, I know that's what it was. And there was probably a couple years where nothing happened to me. And then one day in high school, while playing basketball, I went up and blocked a ball, and my arm came completely out of the socket and stayed out of the socket. At that time, I went to the emergency room. They put the arm back into socket, and then I went through some physical therapy for a few weeks.
There's some Ritz in there, guys.
And then over the course of 4 years of college, even while being an athlete on the soccer team, I would have my arm come out of the socket and put it back in. And through the years, it became looser and would come out of the socket more frequently for very unusual reasons. I've thrown it out sneezing. I've thrown it out playing tennis. I've thrown it out sleeping. I've thrown it out while skiing, and if I had to estimate over the period from 1983 up until about 2 years ago when I had the procedure, my arm probably on average came out of the socket 10 times a year. And on 2 occasions, I had actually gone to various orthopedic surgeons to ask them, what should I do about my arm? And I heard different opinions about what I could do to treat the dislocating condition, but I always felt uneasy about the fixes that were being described to me. Okay, Matt, let's have you bat first, then Grant, and then Abby. Sound good?
Yeah, sounds good.
When he came to me, we got studies. We had an MRI performed and a CT scan that showed that he'd torn the ligaments at the front of his shoulder that keep the ball stable in the socket. He'd also had one of these larger bone defects in the back of the shoulder. And so the only option that sort of existed to treat this would be to take a bone graft from his hip or elsewhere in the shoulder and to add more bone to the front part of the glenoid socket to try and keep the shoulder stable. The problem with that procedure is that, again, it's a non-anatomic procedure. We're basically making the anatomy of the shoulder even more abnormal to try and compensate for the abnormality that was really causing him to dislocate repeatedly. What I'd talked to him about doing was trying a technique that we'd worked on in the lab that would allow us to put a surface area back into the region where the bone was missing in the humeral head and also repair the ligaments so that he wouldn't have this problem with dislocating over and over again.
The procedure appealed to Eric. He'd considered surgical options before, but hadn't felt comfortable with traditional techniques.
When I saw Chris for the first time and he described what he would do, he used this phrase, anatomically correct procedure, where we return your arm to its original state. that sounded great to me as well. Very different from the 2 prior procedures that I'd heard about.
It's over a switching stick.
This was the repair technique that Dr. Wall had been developing to restore the surface of the shoulder head. He'd been researching the technique and performing it in his lab, but had not yet performed the surgery on a patient. After years of waiting for the right surgery to come along, and after thorough discussions with Dr. Wall, Eric was ready to give it a try. He understood that he would be the first patient to have the Daisy Graft performed, but he knew that it was the product of a long and methodical series of careful steps.
While this procedure was progressive, because I was the first one to get it, I didn't feel concerned about that at all, because I felt like, well, one, if you look at Chris's credentials and his experience, it's truly world class. And if you listen to him describe the anatomy, he's actually quite conservative. So it's progressive procedures getting us back to more of a normal, natural state, rather than doing something anatomically radical. And that just resonated with me.
I think it is a leap of faith on any patient's part if they're going to be undergoing a procedure that's different than what's the accepted standard of care. I felt quite confident that we were doing something that we had all the bugs worked out on, and we were doing something that wasn't a big step from things that had been done before. So I felt very confident that what we were offering Eric was actually better than what existed there before. And we'd had opportunities to work on this procedure and check its efficacy in the lab before we ever considered doing it with Eric. The Arthroscopy Lab is an environment where we have all the instrumentation and equipment that we do in the regular operating room, but instead of working on patients, we're working on donated organs. It's an environment that's very, very similar to the real surgery, with the anatomy and everything exactly the same as it would be in the operating room, but there's no risk to causing damage or to damaging someone's health.
Eric has had great results from his surgery. He reflects on how life would have been if he hadn't gone ahead with it.
I either would have had a shoulder that I just continued to suffer with and let it come out of the socket and, you know, deal with the issues there, and probably had a terrible case of arthritis by the time I got into my 60s and 70s, or I would have had a fix that would not have allowed me the range of motion in my shoulder, the natural flow and function that I currently enjoy today. So it's returned, you know, my body's condition to something that I remember from my youth, and I'm extraordinarily grateful for that. Guys, you coming in?
Yeah, I think so. Let's take a couple more.
The innovative surgery performed on Eric was developed in an academic medical setting that supports ongoing research. Ultimately, that research directly affects patient care. Here in UW Medicine's Institute for Simulation and Interprofessional Studies, or ISIS, models can be used to develop new procedures. Simulation technologies are available to teach a new generation of physicians, and experienced surgeons can practice new techniques.
It's a place where we can develop and perfect surgical techniques that are new and exciting, but do them in a very safe, controlled manner where no patient is going to be harmed in any possible way. We're working on plastic models, and we get the technique down perfectly. And then we're ready to practice it on a cadaver. So the development of a new technique and the discovery of newer and better ways to take care of patients is what ISIS is all about.
At the ISIS facility, medical professionals can work with the most sophisticated simulation equipment, or in some cases, on the simplest models, like this one that Dr. Winston Warme built himself. With this large-scale model, it's convenient to visualize one part of the shoulder's anatomy, and it's big enough to demonstrate procedures to others. Dr. Warme is an orthopedic surgeon specializing in shoulder and elbow problems. When he's not in the operating room or exam room, he's working on the development of new surgical procedures.
Can you come back this way?
It's starting to hurt.
Dr. Warme sees patients at the University of Washington Medical Center's Bone and Joint Surgery Center.
Patients come to see me when they have problems with their shoulder and elbow, sometimes sports related or just from falling and hurting themselves, and they want to be put back together. Sometimes we can do that with just exercises. Sometimes it takes surgery.
Basketball is really important to me because I love the sport and it's very fun and I have a lot of passion for it.
Brianne Goulet plays competitive basketball 11 months of the year. But when she broke her collarbone, it wasn't on the basketball court.
I went skateboarding down this hill on my way to my friend's house, and it's not something I normally do, so I caught a bunch of speed as I was going down a really steep hill, and I jumped off my skateboard because I didn't want to hit the cars at the bottom of the hill. So I jumped off and I rolled, and then I heard a pop.
I was actually at work, and I got the phone call that they were at the emergency room. Brianne had hurt herself.
Brianne had a very severe fall skateboarding and landed right on a curb, and she impacted her collarbone in this direction, bending it down. As you can see here, there's a very severe bend in the bone. It's normally a very straight bone, more like this. So she came to the emergency room, obviously in a lot of discomfort, and the first thing we tried to do, of course, was just to straighten it out. And we were able to do that, as you can see on this picture. It's beautifully straight, and it was our intent to just treat her with this and not perform any surgery on her. However, as she was going to the X-ray machine to get another picture, the bone displaced. This is the picture here that shows the bone now has shortened, and the two pieces, instead of being like this, have gone by one another. We call that bayonet apposition, but you can see a lot of shortening here in the bone. And one of the concerns with a lot of shortening is the strength of the muscles afterwards. And we know that the body was designed to have muscles at a certain tension so that they can develop force. And when the bones are shortened, the muscles can't generate the same amount of force, and people end up with some weakness. And Brianne's a very competitive basketball player who hopes to play in college and perhaps professionally, so we thought that she might benefit from surgery. We placed a small pin across the fracture utilizing very, very small incisions, which are very cosmetic, and essentially got the bone to line up nicely such that she would be out of pain and able to begin actually shooting a basketball in a couple weeks.
Get out of here.
The few days before she had the surgery, she was in so much pain, sitting on the couch. She couldn't move, she couldn't lay down. Right after the surgery, her pain level was significantly less to where she actually could be comfortable. It was more about her feeling better than being able to get back to play quickly, which of course was a consideration with her basketball, but just within a day, she felt so much better than she did the whole 3 days where she was on the couch just in tremendous pain and couldn't move.
I think one of the things that surprises patients is they think that they're going to be hurting so much after surgery. And often they feel better after surgery because the ends of the bone are no longer rubbing and grinding and popping and clicking, which is very uncomfortable and disturbing to patients. And once the bone is in a correct position, they feel better. Even though they have a small surgical scar, they're more comfortable.
Watching her commit to something and work really hard on her basketball, it makes me just swell sometimes watching her play. I'm so proud.
Brian Davis is a triathlete. His collarbone broke when he crashed his bike.
I went to a race at Mason Lake out on the Olympic Peninsula, and I got a little aggressive. I got a little too close to the guy in front of me. It was my first competitive race, so I thought I could cut it a little closer than I actually could. And I tagged his rear wheel with my front wheel, and then everything just kind of tumbled, and I rolled around for a while and came to a stop on the pavement. And rolled around on the pavement, picked up my stuff, walked over to the side of the road, and the chase car came up behind me, and the guy said, "Are you all right? What's going on?" I said, "I broke my shoulder." It was pretty obvious that my clavicle was broken. I could feel it moving around inside when I tried to move my arm.
After emergency treatment and evaluation at Harborview Medical Center, Brian needed to follow up with a specialist. A fellow triathlete recommended Dr. Warme.
I went in and talked with him. He kind of laid out the options in plain English, really easy to understand. He said, you know, I could have surgery if I wanted, but he said I was young and pretty resilient, so, you know, why not wait and see if maybe it would heal together on its own. So he said about 6 weeks or so, come back in and we'll see how healed up it is. And it started feeling a little bit better. I came back in and it hadn't healed at all. I was just kind of getting used to it being disjoint. And so he said, you know, I could continue to have it that way if I wanted, but I wouldn't be able to swim the same again or anything like that. And I really wanted to restore my previous range of motion, especially in the water. So he said surgery was probably the best way to go.
Brian's an executive now, but former Division I swimmer and a very athletic triathlete at this point, very interested in training and performing at a very high level. And he sustained a very serious fall off of a bicycle in a race and broke his clavicle or his collarbone and his scapula or shoulder blade in the same fall. Collarbone fractures are very common, especially in the middle of the collarbone, and they're often sustained by children on playgrounds and other things, and the traditional wisdom has been to leave them alone as they normally will heal up. And in the young, active child, these bones heal amazingly well. However, in adults, especially when the bones are very displaced and there's a lot of shortening at the fracture site or the bone ends are far apart, then there's problems with healing. Sometimes the bones won't heal and they'll remain painful for long periods of time. Alternatively, they can heal in a malunited or unusual position, which is also uncomfortable and can require a more complicated surgery. So over time, we've found it's more effective to intervene early on these fractures, get the bone back to its proper length and rotation, and get people back to the activities that they enjoy.
I had thousands of questions, and what questions I didn't have, my mom had, or my sister had, or my wife had. So I was worried, you know, would I get my range of motion back? My friend had minor surgery on his shoulder and has never gotten his range of motion back for that one shoulder. So it wound up making his stroke very lopsided, and it's something very difficult to deal with in the water, especially for repetitive motion. I was worried that I wouldn't be able to get back into a competition in a reasonable amount of time, that I would become very out of shape and I'd have to work for months and months and months to get back in shape.
This is an x-ray of Brian's left shoulder, and you can see a fracture here of his clavicle, which is quite displaced. He also has a fracture of his shoulder blade, which we call the scapula, and you can see that line that's fractured through there. It doesn't enter into the shoulder joint, but it's just below it, and it indicates how severe a fall he had, and he would have had to land very, very hard to break his shoulder in two places like this.
Dr. Warme repaired Brian's shoulder using a plate that attached with screws to both pieces of the bone. The plate bridges the fracture site and restores the collarbone's normal length.
And now you can see that we've applied this plate to the bone, and the bone is uniting. Not only has the bone united here, he's developed a lot of new callus or healing woven bone that's underneath. On this view you can see that more clearly. His body has worked over time to really create a very stable situation. After the bone was held with the plate, then the body was able to heal. On this one you can see that the fracture through the scapula or shoulder blade is also healed very nicely in a very good position. Actually, we were able to get a very anatomic repair. In other words, the bones are all back in the right position and the right length. and that allows his muscles to function at their optimum ability and strength. So we think he should be able to be back to swimming and doing all the things he likes to do.
The best thing I can say about the surgery is that it feels as though nothing ever happened. If it weren't for some extreme angles of motion, or some of the wackier things I do when I'm swimming or biking, I would never notice that this shoulder is any different from the other shoulder.
As a competitive swimmer, Brian really needed his injured shoulder to get back to full function. He appreciated that Dr. Warme understood his athletic goals.
He had dealt with athletes before, and so he understood where my values would be as opposed to, say, a reasonable normal person's values might be. And he kind of had to center me a little bit. I had to accept the fact that if I wanted to heal up correctly, I'm not going to get back in the water next week or right after surgery, that I had to give it some time. And on the checkups, I was continually trying to push it, kind of argue with him and see if I could start swimming a little bit earlier, start developing my stroke as fast as I could so I could stay in shape. And he was very good about giving me small milestones that I could focus on that would keep me in shape, but at the same time wouldn't stress my shoulder or tear things up in here. So he said, you can get back in the water, but you can only kick. You can swim with one arm but not the other. You can do drills. And he was really open to try and help me with, not totally devastating my goals, but at the same time, getting me back on track to recovery. If I could give Dr. Warme a hug, I absolutely would. That guy he's a kick-ass physician. He's a really cool guy.
For more information, to make an appointment, or to refer a patient, contact the University of Washington Sports Medicine Clinic at 206-543-1552, or contact the Bone and Joint Surgery Center at the University of Washington Medical Center at 206-598-4288, or go to www.orthop.washington.edu.